All right, so I suppose we'll get started with the practice questions. It's very quick, inshallah, won't take more than 40 minutes, hopefully. So let's get started. So I'll just read some of the questions that I've curated over here from multiple sources. Give like 30 seconds till like an answer comes through, and then we'll just reveal the answer right away. That's how we'll conduct it. All right, let's get started. So for the first question, 68-year-old man comes to the office due to worsening nocturia for the past several months. Lately, he has been waking up every 3 to 4 hours at night to urinate, which is severely disrupting his sleep. The patient also has increased urinary urgency, frequency during the day, but no pain or burning sensation. He has a history of hypertension and takes an ACE inhibitor. The patient has a remote history of smoking and does not use alcohol or drugs. Blood pressure is 130/80 and his pulse is 82. The abdomen is soft and non-tender. There is no costovertebral angle tenderness, and his rectal examination shows a diffusely enlarged non-tender prostate with a smooth surface. Which of the following is the best next step in his evaluation? So essentially what you're trying to do here is find out what the next best step is. So since he is being unable to urinate for the past 3 to 4 months, this likely turns with no other like conditions or risk factors that seem to be happening here. His only complaint is difficulty urinating and urinating at night. The most likely diagnosis in this case would be benign prostatic hyperplasia. And in that case, we just got to find out what to do next after we diagnose benign prostatic hyperplasia. So in order to diagnose it, we need a very specific modality. We do not need any specific modality, and the most likely answer within these is a urinalysis. So let me reveal that. There we go. So the reason we do a urinalysis is not because we want to diagnose BPH. It's more like to rule out other causes because his symptoms are very unspecific in this case. The only symptoms he is having is difficulty urinating, which like excludes most of the conditions that are like investigated through the following modalities such as a cystoscopy, a urography, or a prostate ultrasonography or a transrectal prostate biopsy. Now, the reason we don't do these, despite him having like prostatic hyperplasia, is because these are very invasive and there's no need to do any of this. BPH is a diagnosis of exclusion. You can diagnose it clinically. So the only thing you really need to do is rule out a secondary condition like a UTI through a urinalysis. So again, any patient with lower urinary tract symptoms should be initially tested with a urinalysis for any like bleeding. So if we find any bleeding on your analysis, then that could point us more towards cancers or stones rather than BPH. But other than that, it's pretty straightforward. So here's a quick URL table I stole. So you can have a read at it later. I won't be going through it, but here's some risk factors between differences between BPH and prostate cancer. All right, so for the next question. So a 20-year-old presented with difficulty initiating urination and stopping urine flow. Upon further questioning, it is revealed that he's also been suffering from increased frequency of urination with urgency and post-void dribbling. The patient also mentioned that he had been catheterized in the past after suffering from a severe car accident 5 years ago. Which of the following is the most likely diagnosis? So in this case, we're also having another patient who is having difficulty urinating, except this time we're not really looking at an elderly patient, we're looking at a very young patient. So that changes the differential in this case. So instead of being more of a prostatic problem, just as in the previous question, we're thinking of other things that might impede urine flow in this patient. Now, very importantly mentioned in this question is that the patient has been catheterized 5 years ago. The reason this is important is that it could have been the cause that eventually led to the urine obstruction of this patient. So in this case, the most likely cause of this urinary obstruction would probably be a urethral stricture. The reason is The catheter from 5 years ago when he suffered an accident most likely injured his urethra, which would result in the formation of like granulation tissue, fibrosis, and eventually that causes stenosis of the urethral tract, which will end up with by which you'll end up with a urethral stricture. Now, in other cases, if the patient were to not have like a secondary condition, in this case, or a secondary cause or risk factor that may have resulted in him being obstructed, such as in the case of putting a catheter in, then the most likely diagnosis would be a stone. So a stone, a kidney stone, will result in difficulty urinating as well. So like a stone in the bladder. If you take a look over here, again, the answer is urethral strictures. Its most common cause is usually iatrogenic, but you could get it through congenital, such as a posterior urethral valve, or a post-infectious process. For example, if a patient presents to you with outflow obstruction and they have STIs, and you've realized that they've been diagnosed with the chlamydia or Neisseria in the past, the cause of obstruction could be secondary to urethritis, which again causes inflammation, eventually stenosis of the urethral, what do we call it, of the urethra. So in this case, since you are diagnosing urethral strictures, your labs in like following up is the same as the one earlier. We mentioned we always start with a urinalysis. After we figure out like there's no hematuria, rule out everything else that maybe like could be another differential diagnosis such as a UTI. We can also perform a renal function test. The reason we do a renal function test is because we are obstructing the bladder. And when we are obstructing the bladder, we are causing a susceptibility of the kidney to suffer from a post-renal acute kidney injury. And this post-renal acute kidney injury can damage the kidney and it could lead to a chronic kidney disease, especially if the obstruction has been like very prolonged. So we kind of want to just make sure that the kidney is doing fine. Other than that, your imaging, usually we do a non-contrast CT for kidney stones if we are suspecting kidney stones. We could do an ultrasound as well, but usually this is more like of an emergency case. We really focus on the non-contrast CT if we are suspecting kidney stone. So this is the order by which I would go with bladder obstruction. So you would go with first off, very first thing is to make sure, like, if they are obstructed acutely and they're suffering from like bloating symptoms, is to clear out the bladder. Once you make sure that the bladder is empty and that the patient is stable, you can then start with your what do we call it, a process of diagnosing the patient. So you would start with like a physical, a history, history, then physical, and then you can move on to your labs and then your imaging. So the most important thing is to start with clearing the relieving the obstruction and then moving on to the diagnosis process. All right. So this is from Ambos. The most common etiology of urinary tract obstruction is dependent on age. Again, we really need to focus on age. In this question, it was 20. In the previous question, it was 68. So depending on the age, if they're very young, like an infant, then we're looking at posterior urethral valves. If we're looking at adults that are young, we're looking at kidney stones. And if we're looking at older adults, then we're considering more prostatic issues like BPH or a prostate cancer, though usually it is BPH. All right, for the next question. A 32-year-old a 32-year-old man comes to the clinic, the infertility clinic for an evaluation. The man and his wife, who's 31, have been trying to conceive for the last 15 months and have had unprotected sexual intercourse several times per week. The patient has no chronic medical condition, has no and takes no daily medications. On physical, testes are palpable within the scrotum and they're normal in size. There's no excessive firmness or tenderness within either testes. The left testes is positioned lower than the right one, and superior to the left testes, there's a non-tender clustered mass. It does not transluminate, meaning they shined light, but nothing went through, and it decreases in size when the patient is supine. A semen analysis shows that there's a normal seminal volume, but slightly reduced sperm count and decreased motility, which of the following is the most likely diagnosis of infertility in this case. So, um, like to tackle this, we need to find out the diagnosis in this patient. So for infertility clinic, so someone answered in the header. Yeah, you are right. It is E. So it is a varicocele. The reason is because it is the most common cause of infertility, or sorry, the most common treatable cause of infertility in men. And it is like described here. It is genuinely just describing a varicocele over here, non-tender clustered mass. Um, all other causes are more like congenital or like it wouldn't show these findings that are consistent with the semen analysis. The absence of the vas deferens will not show us sperm count on semen analysis. Ejaculatory duct obstruction, same thing, will not show this. These are functionally the same thing. Inguinal hernias, not really implicated in this case. And hydroceles are more congenital and they usually do not really cause infertility. And therefore, varicocele is the most likely answer in this case. So for male factor infertility, we're looking at what do we call it? Your causes here. Your main two causes for male factor infertility are exogenous steroids and varicoceles. So whenever you're thinking about like infertility in a man, your thoughts should immediately go, is this guy using steroids or does he have a varicocele? Other than that, it's usually idiopathic. Now, its etiologies is divided into two, either primary or secondary hypogonadism. I'll like elaborate on this in a later slide in this presentation. But basically, it's either problems with the testes themselves or problems that are secondary, like such as systemic causes or something that's going on in the body itself, like hormonal. Your any couple that presents you, this is the most important thing about this, like the for the urology segment. The most important thing is that a couple with infertility, and infertility is defined as 1 year of trying to conceive, but failing to do so, like doing unprotected sex and just failing to conceive. Your first test that you should ever perform is always a semen analysis. Even if it's like, even if you're suspecting female infertility or like idiopathic infertility, there should always be a semen analysis. The reason we do a semen analysis always first because it's really cheap and it's super fast. And it's really non-invasive. It's super easy to perform. So we prefer to do the semen analysis very early on. And if the semen analysis is normal, then we can proceed to other modalities to diagnose infertility, but usually this is the one we start with. I'm not going to delve too much into the infertility like workup because that's more of a fourth year thing during urology and during OB/GYN. So the only thing you really need to focus on is that the first modality or the first test that needs to be performed is a semen analysis. Now, as far as treatment is concerned, it's really just about fixing the cause if there is a fixable cause. So it depends on etiology. So if we have a varicocele, then we're going to attempt to fix the varicocele. Now, the reason varicocele causes infertility is because temperature rises in the testes, and that causes sperm atrophy or testicular atrophy, and then the sperm like are unable to move, and therefore there's no fertility. If the patient is taking exogenous steroids, then we obviously stop steroids. Now, in the case that a patient comes to you and they've already done a semen analysis and they don't have a varicocele or steroids, they have something like a cystic fibrosis where their what do we call it? Their vas deferens is bilaterally congenitally absent. What you would do in this case is immediately go for reproductive assistive reproductive technology ARTs. So what you could do is an IVF, an ICSI, or any other reproductive technology that can help the patient conceive. Because in the case of cystic fibrosis, for example, and they have congenital absence of the vas deferens, the testes are actually normal. So spermatogenesis is fine. So what you could do is extract sperm from the testicles themselves, and you can take those and inject them straight into eggs. Or you can just put them in IVF, like you put them in a plate and then let the like the sperm swim over to the egg and fertilize it that way. So, like, if you get a question that asks you about what the next best step is, and there's no Varaxil or steroids, you could just go straight for assistive reproductive technology. So, for Varaxils, this is a quick table if you want to just look at the findings here later. It's just basically what we said. So, for the next question. A 28-year-old man comes to the physician for evaluation of infertility. He's healthy. He has no other complaints. He eats a high protein diet and exercises daily in order to be muscular. He weighs 85 kgs. He's 175 centimeters and his temperature is 37.2. His blood pressure 130 over 82. He has small testes. The remainder of exam is normal. He has very high hemoglobin. His LH is low and his serum testosterone is fine, which is the following is the most likely cause of infertility in this case. All right, great. It is C. So the reason it's C, it's again exogenous steroids is your second or first first likely cause of infertility in men. The reason is, as we mentioned earlier, steroids will interfere with the process of spermatogenesis, and then therefore that will cause infertility. Usually when you get a patient who's a bodybuilder, it's very likely to be a scenario on steroids, especially if they're presenting to the infertility clinic. One hint here that points you more towards exogenous steroids, or sorry, two hints here that point you towards that way is the small testes. When you give a patient testosterone exogenously, that suppresses like the GnRH pituitary axis. And with the absence of FSH, LH, those hormones, this causes the underdevelopment of the testes and that causes their atrophy. Another hint is the high hemoglobin. Testosterone is a stimulator of EPO or erythropoietin, and that causes increased what do we call it, erythropoiesis, and therefore will cause a polycythemia. The labs can also help you over here, though I don't know if they'll give you labs in your exam. I don't know if you guys took this. I took these questions mostly from either UWorld or AMBOSS and even your past exams. So in this case, um, your LH level will point you more towards exogenous steroids because when you're introducing testosterone exogenously, that will suppress the endogenous system of hormones, which will cause low LH and FSH. And that will also cause a normal testosterone level because your exogenous testosterone will not be picked up on a test. It'll just show up as testosterone. So that's the reason why exogenous steroids is the cause of infertility in this case. So exogenous steroids suppress the hypothalamus. There's no release of GnRH, which impairs spermatogenesis. Now, for the causes, as I mentioned earlier, they're hypogonadism, secondary hypogonadism. I would really just focus on the testicular causes here. You really don't need to worry about most of these because these will be covered later. What I would worry about is just varicocele infections, such as either congenital mumps, or sorry, not congenital mumps, such as a mumps in a patient who is not vaccinated when they were young. So they'll get an orchitis, or any patient that has urethritis with gonorrhea or chlamydia. Patients who have testicular torsion, which will show up later. And then patients who have cryptorchidism, which is the failure of the testes to descend during the what do we call it, the embryo process. They are supposed to go through the inguinal canal into the scrotum, but if they get stuck at any point between that, like in the abdomen or in the inguinal canal, then it will be cryptorchidism. That will cause what do we call it, infertility in a patient because sperm is temperature sensitive, of course. All right, so further cause is not really important. I wouldn't really focus on it, except exogenous steroids over here and medications. Other causes, like there are various different etiologies and pathomechanisms that we can look into, but it's not really necessary. The only one that I would really maybe consider looking at is hyperprolactinemia. But other than that, none of these really matter. Maybe Kalman syndrome as well. So that's it for the causes of infertility. We can move on to the next question. So a 65-year-old man recently retired after many years in a job that is involved or with exposure to aniline dyes, which includes naphthylamine. 1 month ago, he had an episode of hematuria and was not accompanied by any pain. On physical, no abnormal findings. Urinalysis, he had hematuria, but nothing else. Microscopic examination of the urine shows RBCs that are too numerous to count. 5 to 10 WBCs per high power field and no crystals or casts. Urine culture is negative. What is your next best step? All right. So let's tackle this slowly. So this patient has painless hematuria. That's his only complaint in this case. And very importantly is that he works with aniline dyes. So what we're thinking of with the differentials is bladder cancer. This is the most important differential in this case. So when we're thinking about bladder cancer, we want to consider which modalities is most useful for us. So yeah, um, the most useful modality in this case would be a cystoscopy. The reason cystoscopy is very important is because we can directly visualize the bladder. The reason that's important is because bladder cancer, like specifically transitional cell carcinoma, is most likely to show up on the bladder itself rather than the ureters or the kidney itself. It's very rare for a bladder cancer, transitional cell carcinoma, to go all the way up to the kidney. And that's why a renal ultrasound wouldn't be really useful in this case. Because he doesn't have a flank pain or any other abdominal pain, again, that does not like guide us toward a renal ultrasound because the only reason I would do a renal ultrasound really is to check if there's a kidney stone. In this case, I'm not really suspecting a kidney stone in this case, so I would move more towards a cystoscopy. CT pelvis is not really that ideal for a bladder cancer. The most important thing is cystoscopy for bladder cancer. CT pelvis, I would use it more for like kidney cancers or even kidney stones. That's where I find it more useful. So again, your answer is cystoscopy due to a suspected urinary bladder cancer. Forgot the word cancer here. So for hematuria paradigm, the way I would tackle it is you do your physical, you do your history, whatever. When you work on labs, your first thing that you want to do is a urinalysis. Since the urinalysis is already done here, we didn't really need to pick that option. After urinalysis, a microscopy is important to visualize like if there's any crystals, to visualize if there's any other abnormalities like infection, anything like that. After we do that, we can do a urine culture. After we do that, and all of them are like depending on their results, we can like consider different modalities. If it is isolated hematuria, there's only blood in an older patient. If you notice, the patient is 65 in this case, then our differential here will be most likely bladder cancer, and we want to rule that out through a cystoscopy. If we are presenting with colicky pain with a negative culture and there's crystals in the urine, we're thinking more of a stone, then we can go for a CT abdomen and pelvis. So that's how I would handle the hematuria questions when they come to you in the exam. And of course, if there's any confusion, just ask in the chat. We can move on to the next question. Again, on a similar theme, a 49-year-old woman presents with to the ER from severe flank pain for 4 hours. She has been vomiting for the past 2 hours continuously. She has been experiencing dysuria and a fever for the past 2 weeks. On examination, she has costovertebral tenderness. Her urinalysis revealed significant hematuria. Microscopic examination of urine demonstrated crystals and coffin lid-like appearance. Which of the following is the most appropriate treatment for this patient? I'll give you like 20 seconds. Amorphous carbonate CAP. So I'll let you know after. Okay. So, all right. So let's start here. So this patient obviously has a kidney stone, okay? Now, the most important thing we want to find out is what type of kidney stone she has. So in this case, immediately we really don't need to look at any of this stuff. We just need to focus here on the crystals. So the crystals tell you that they have a coffin lid-like appearance. Coffin lid-like appearance is characteristics of AMP stones, ammonium monophosphate, and those are most likely found in a struvite stone. Struvite stones, yes, it is alkaline urine. So for struvite stones, the urine will be alkaline due to the AMP stones and most likely caused through a secondary infection with like Proteus due to the breakdown of urease, which will like promote the formation of stones, which are AMP, and that causes struvite stones. Now, struvite stones are very big. They're really, really big, and they fill out the whole renal pelvis. So we can't really depend on very small measures to like handle kidney stones, like supportive measures or even like shock waves. So we really need to go into like big modalities right away. So in this case, the most important modality and the most like effective modality in this case with the least side effects would be B, which is percutaneous nephrolithotomy. Percutaneous meaning they just go through the skin. Nephrolithotomy is just opening out the kidney and removing the stone. The reason we don't go for an open surgery is because the outcomes are really bad for open surgery. No one really does open surgery anymore. And the same thing goes for endoscopic lithotripsy. Again, these are just for endoscopic lithotripsy, it's more for small stones. Open surgery is just associated with very poor outcomes in general. And then ESW or shockwave is for smaller stones, and struvite stones are usually very big. So it's not really useful in this case. Our answer would be a percutaneous nephrolithotomy. Now, this is taken directly from your slides, so we don't like mess a lot of things up because like different sources say different things. So for your management, if your stone is between 5 to 6 millimeters, then supportive therapy is most indicated through a alpha blocker with analgesia and a lot of fluids, about 2 liters of fluid per day. If your stone is less than 20 milliliters, or sorry, millimeters or 2 centimeters, then you want to go for shockwave therapy, ESWL, or you could also consider endoscopic lithotripsy or lithotripsy. If your stone is very big or complex, then your most important modality is a percutaneous nephrolithotomy. Again, the reason is it's associated with the lowest outcome, the best outcomes, and it's the most useful in the case of removing large kidney stones. Okay, I think that should be clear here. Like again, your most important thing here is the stone size. Stone size really regulates how you would treat the kidney stone. If it's less than 5 millimeters, supportive. If it's less than 20, but over 5, then you can use shockwave or endoscopic lithotripsy. And if your stone is very large, more than 20 centimeters, or sorry, more than 2 centimeters, then you're looking at percutaneous nephrolithotomy. All right, for the next question. So you have a 36-year-old woman who's presenting to the clinic with inability to pass urine for the past 36 hours. She's in complete discomfort and distress, and upon examination, you found a very enlarged suprapubic area. So what's your next best step of management? All right. So as I mentioned earlier, for patients who have obstruction, in any case, your most immediate concern is to relieve the obstruction first, then we can work it up. So in this case, we want to insert a catheter before doing any testing because the woman is in complete discomfort. She has been unable to pass urine for like 36 hours. So that's what we would go for first. After we deal with the immediate concern of the patient, then we can start working up the patient. So our like order would be a urinalysis, followed by like a urine culture, and then we can do labs for kidney. We can do imaging after that to find out the cause. We can do a CT of the pelvis, for example, if we're suspecting a stone, etc. So our first thing that like the most immediate concern would be to insert a catheter. Again, the reason is it's something that's like very treatable very quickly. And if you leave it in there while you work up other things, the patient may deteriorate. They may develop AKI, post-renal AKI, which could eventually lead to chronic kidney disease. And you don't want all that complications. We can just deal with the patient's concerns right away, pass a catheter, and then we can work up the patient after that. Again, the same principle from the question before. Let me find the previous question. So the same principle, the BPH question over here. You do a urinalysis first. Oh, sorry, you treat the patient's concerns first. You do a urinalysis, and then you can move on with your paradigm from there. It's very simple, very straightforward. All right, for our next question. So you have a 25-year-old patient who was previously healthy, and then he suddenly developed very severe pain in the scrotum. His pain like continued continuously for 6 hours, and he went to the emergency department. On physical, he is febrile. There's exquisite tenderness and slightly enlarged right testes, and there are no other remarkable findings. So among these options, which one is the most appropriate to diagnose the patient? So yeah, you are right. It is a Doppler ultrasound. The reason we want to do a Doppler ultrasound is because it's showing us blood flow, and because in the case of testicular torsion in this case, an absent blood flow to the scrotum will most likely point you towards a what do we call it? Towards a testicular torsion. All other modalities are not really useful. You don't really need an X-ray in this case because it won't reveal anything. Uh, sorry, you don't need like contrast X-ray for this. Same thing with a regular X-ray, and an angiogram really just focuses on the renal arteries, so you're not really looking into the veins. So it wouldn't be really useful in this case. So your answer is obviously a Doppler ultrasound. Now, I want to point out something very important here. Doppler ultrasound is not usually a modality that is used. If you have a question that asks you what the next best step is, and you are almost certain that the diagnosis is testicular torsion, and one of the options says immediate surgical consultation or immediate detorsion, then that should be the answer. Because testicular torsion is a clinical diagnosis. You do not need imaging for what do we call it? Testicular torsion, unless your physical exam findings are inconclusive. If you're really not sure if it's what do we call it? Testicular torsion, then you could do a Doppler ultrasound. And in a question, there will most likely be very obvious, like this is extremely obvious. So if this is the same scenario with the option down here mentioning immediate detorsion, then I would go pick that option instead. Other than that, it's pretty straightforward. So the options manual detorsion or surgical detorsion, I would pick those over the ultrasound in case those show up. All right, for the next question, we have a 50-year-old to the presenting the ER complaining of fever, weakness, and severe flank pain. He's reporting that he's been passing dark-colored urine on several occasions during the past month, but he has no urinary frequency, dysuria, or nocturia. On physical examination, he is slightly febrile. His blood pressure is normal. His urinalysis shows a +4 hematuria, +1 proteinuria. There's no glucose or ketones. Which of the following procedures is the most appropriate in management of this patient? So I'll give you just a few seconds before we can answer this. All right, so let's start answering it. In this case, we are suspecting a kidney stone. Again, the patient has very severe flank pain, they're febrile, and they have hematuria in their urine and a little bit of proteinuria. Now, since we are suspecting a kidney stone, we want to use the most we want to use the most useful modality to diagnose a kidney stone. In this case, your most useful modality would be an abdominal and pelvic CT without contrast. The reason we don't really use a renal ultrasound, as I think someone answered in the chat, is because renal ultrasound will really just show you stones within the kidney themselves and will not show a stone within the ureter or within the junction between the ureter and the bladder. So you wouldn't be able to diagnose it that way. So I would go with an abdominal and pelvic CT without contrast because most stones will show up on abdominal CT. The reason we don't want to use contrast is because the kidneys are damaged and contrast usually is nephrotoxic and we don't want to expose the kidney to more nephrotoxic substances and we want to preserve kidney function. So for our diagnosis, we would use an abdominal and pelvic CT without contrast. So suspected renal masses or stones is the reason why we decided to use a pelvic CT or abdominal CT. His presentation is super acute, which means that it could be a stone. CT scans of the abdomen and pelvis are obviously the most useful for diagnosing kidney stones. And then if he doesn't have a kidney stone and say he has like a renal cell carcinoma, then a CT is more useful than an ultrasound anyways, because you can spot like tumors that are definitely obstructing the ureter at any point or within the kidney. Now, again, ultrasounds may not also catch stones that are radiolucent, such as uric acid stones. So it's not really useful for you. So I would go with the CT. Now, CT obviously doesn't show a kidney. So CT sometimes doesn't show a uric acid stone, but it may show them sometimes. So I would generally go with that. So again, this is extracted from amboss, CT, abdomen, pelvis without contrast, and ultrasound of the abdomen, pelvis are the preferred diagnostic choices. But if you had to pick between them, I would pick the CT abdomen. Now I know it mentions both in this case, but CT abdomen is more important here than the renal ultrasound, at least according to your lecture. Right. Let's go to the next question. So this is very easy. Which of the following represents the most significant risk factor for the following finding on cystoscopy? So this is the bladder. All right. So this is fairly straightforward. You just need to know the risk factors. Now, bladder, again, this is bladder cancer. We're looking at bladder cancer over here. Now, our choices will be smoking as the most likely risk factor for bladder cancer. It is really important. It's more important than other causes of bladder cancer, which are listed here. These are all risk factors for bladder cancer. Yeah, it is bladder cancer. This is bladder cancer. This is a cystoscopy. Cystoscopy is to look at the bladder. So because working in an industrial factory will expose you to like dyes, which could be risk factors for bladder cancer. Not sure about autosomal dominant polycystic kidney disease, but it could probably be a what do we call it, risk factor for bladder cancer. Schistosoma is also a risk factor for bladder cancer, and so is a kidney stone because it can cause chronic inflammation. Now, all these are like risk factors, but the most significant among them is smoking. It's the most documented. It's actually the most important risk factor because of a substance called 2-nephthylamine. Uh, it causes an effect in the bladder called field cancerization. Though this is like kind of out of scope, but like the most important thing to know here is that smoking is the most associated with the bladder cancer. It is associated with both squamous and transitional cell carcinoma. That's why it's really significant. And as I mentioned, all other options are associated with bladder cancer as well, but smoking is the most significant among them. All right, let's do the next question. A 23-year-old man presents to the clinic feeling a mass on his right testicle. The patient's history of presenting illness is unremarkable. On examination, there is a hard testicular mass on the right testicle. Following biopsy and staging studies, it is revealed that the tumor is a seminoma that is confined to the testicles. Which of the following is the best next step? All right, let's start answering the question. So, since we're working with a seminoma here, and a testicular tumor, um, these tumors are generally can transform into very aggressive variants. So your option of treatment will most likely be an inguinal orchidectomy with radiotherapy. Now, the reason we do what do we call it, an inguinal or orchidectomy with radiotherapy is because these cancers are super treatable in that what do we call it environment, and we do not really want them to progress. It's not like prostate cancer where you can just watch it because most men die with prostate cancer rather than because of prostate cancer. So in this case, since the patient is really young and that the cancer can be aggressive later on, we want to remove it right away rather than let it like simmer and like cook in there. So we don't really want to observe it because that could kill the patient. So our most likely option here would be an inguinal orchidectomy with radiotherapy. No one really does transscrotal orchidectomy, which means like going and cutting th through the scrotum and then removing the testicle that way, because that's associated with like bleeding and fibrosis. So the most useful modality in this case is to go through like the inguinal canal and then remove the testes that way and then support it with radiotherapy. I think someone typed into chat. Yeah, okay. All right. So again, based on the slides, just to not like mess anything, seminomas are radiosensitive. Stage 1 and 2 are treated with inguinal orchidectomy with radiotherapy. And then we surveil it after. So surveillance does not mean observing that and just letting it like simmer in there. It means like surveilling after we remove the tumor. Anything that's above stage 2, and stage 2 is like defined by staying in the testes. Like if you see it beyond the testes, then you just treat it with chemotherapy right away. There's no need for any surgery or anything like that. So if this question over here, if you go back, over here, if this mentioned that the tumor has spread into the like the abdomen or something like that, or the liver, then chemotherapy would be option here. All right, next question. So 35-year-old woman, mild costovertebral tenderness, no hematuria. She had a kidney stone that measured 7 millimeters on the right kidney. What's your most appropriate option for management? So we discussed this earlier. All right, let's get started. So for kidney stones, again, anything above 5 millimeters but under 20 millimeters is treated through like a invasive option. We don't really rely on conservative therapy for this for these types of stones because they're a little too big, but they're not big enough where we require a surgery. So anything above 5 or 6 millimeters is treated through shockwave, so ESWL. Anything above 20 millimeters or 2 centimeters, like a struvite stone, we can treat with a percutaneous nephrolithotomy. Anything under 5, we can treat with conservative therapy. And then this, again, uteroscopy and endoscopic lithotripsy is, what do we call it? Is also an option in this case, but usually the preferred option is ESWL. Like if you were to pick between these two options, I would go with ESWL first, and then you'd pick this one if that is not available. That is more important. So ESWL, again, the same sequence of what do we call it? The same sequence of answers that we discussed earlier. Anything above 2, treated with percutaneous nephrolithotomy. Anything under 5 or 6 is treated with what do we call it? Conservative therapy. And anything under 2 but above 5 is treated with ESWL. All right, let's do the next question. So, which of the following is correct about PSA screening? It is affected by age. It is not affected by the size of the prostate. It is specific for cancer, or serial measurements of PS are not useful in the management of prostate cancer. All right, great. So A, it's very straightforward. PSA, the bad thing about it is that it is affected by age. So older patients will have a higher baseline level of PSA, which is why like it gets a little confusing with guidelines. The older you are, the higher baseline of PSA. So for example, a younger patient who has a like if you screen them for PSA, their PSA baseline is expected to be under 0, for example, or under 1. An older patient who's like 85 and you measure their PSA, their baseline is about 4 or 3. So it is affected by age. PSA is also affected by the size of the prostate. So if your prostate is bigger, then PSA levels will be expected to be higher. It is also affected by inflammation and prostatitis, which can increase PSA, and that's why it's not very specific for cancer only. Other conditions can raise PSA. And then actually the way we follow prostate cancer is through PSA. So once you diagnose and establish prostatic cancer diagnosis, then you can follow it with PSA, and it's useful in that case. So if these options get flipped around in any other way, just remember the properties of PSA, depending on age and size of the prostate and its relation to cancer, and the way we can use it to follow up cancer. And then you can answer any of the questions that are changed this way. So again, baseline PSA levels changes according to age. As age increases, PSA baseline generally tends to rise. Inflammation, manipulation of the prostate, other malignant or benign prostatic diseases can also lead to a false positive PSA result as well. So that's why it's not really specific for cancer. All right. So we have a 59-year-old woman who presents with painless hematuria with a palpable left abdominal mass. Uh, Her radiological investigation reveals a 6 centimeter tumor on the upper pole of her left kidney. The remaining renal tissue is normal, and the tumor is not metastasized yet. The patient's other kidney is fine. Which option is the best for this patient for treatment? Yeah, it is renal cell carcinoma. So like this, your diagnosis here would be renal cell carcinoma, but which of these options would you pick? Yes, great. It is radical nephrectomy. The reason we do a radical nephrectomy is RCC is a very aggressive cancer. So since we found it at a very early age or stage, sorry, we can just do a radical nephrectomy and just get rid of the kidney entirely just to prevent metastasis later on. Renal cell carcinoma actually is like the reason it's very the reason the reason we don't want it to metastasize is that it's not responsive to radiotherapy nor chemotherapy. It's resistant to both. So the only way you can really treat renal cell carcinoma once it's metastasized is using immunological therapy, like immunotherapy, or biological agents. So it's not really treated with chemotherapy either way or radiotherapy. So your best option here would be a radical nephrectomy and hope it didn't spread. And since the other patient's kidney is fine, it'll compensate for the urine outflow or urine output. Again, radical nephrectomy, unless extensive, this is taken straight from your slides, unless there's extensive metastatic disease, it always involves surgery. Your surgical option is radical nephrectomy. So you can approach it through different ways and incisions. You really need to know that. Renal vein is ligated. The reason we ligate the renal vein is like when we're cutting the tumor, we don't really want it to spread into the renal vein. And then finally, anything that's around the kidney, we need to remove it as well, just in case the tumor like seated in there. So it's really straightforward. RCC treatment is very, very straightforward. It's either if it is confined to the kidney, then you will do a radical nephrectomy. If it is outside the kidney, and then you'll most likely use biological agents or immunotherapy, along with a surgery to debulk the tumor. The reason we debulk it is just for the, what do we call it? It's more like a palliative option to, what do we call it? To like relieve the patient from their flank pain or any hematuria or like urine obstruction. But other than that, there's not really a treatment there. All right. For the next question, a 70-year-old man presents with painless hematuria. On examination, no masses, no tenderness. The patient has no other symptoms. He has a very slightly elevated serum calcium level. What is the best imaging modality to diagnose this patient in this case? And keep in mind the calcium level here. All right. So, since there is an elevated serum calcium level, we are more going towards like we're assuming very ideally, we're thinking more towards renal cell carcinoma rather than transitional cell carcinoma. The reason is renal cell carcinoma is associated with paraneoplastic syndromes where it releases PTHRP, and that can cause a hyperparathyroidism, and that can result in a hypercalcemic state. So, since we are thinking about renal cell carcinoma, your best option in this case would be a CT scan. The same reason we would do a CT scan for what do we call it? For kidney stones. Anything that causes like kidney problems, such as tumors or stones, we usually opt for more towards CT scans rather than ultrasounds right away. Unless there's a contraindication. I forgot to mention this earlier. If there is a contraindication for a CT scan, then you can do a renal abdominal ultrasound. A contraindication would be something like pregnancy. That's what they'll mention. Like the patient is pregnant, so you can't really do a CT scan. So you would go for a renal ultrasound in that case. Best even if that's for a kidney stone. If she has a tumor, if like the patient is suspected to have a tumor, I would use an MRI in that case for renal cell carcinoma if she is pregnant. But other than that, your main option is a CT scan in this case, following the same principle from earlier. So just to summarize it really quickly, if the patient has no contraindications and they have suspected renal cell carcinoma, kidney stones, or any kidney issue like an abscess or anything like that, I would go the CT scan first. If they have a contraindication, then we can go to an MRI. Then we can move to a renal ultrasound, especially if they are pregnant. If we are suspecting cancer, and they are pregnant, an ultrasound wouldn't really help us to stage the cancer, so I would use an MRI. It really just depends on the scenario in this case. All other options are not really useful for this patient since he is male. We don't really need to do an MRI. It's too expensive. It takes way too long. So a CT scan is more appropriate. Intravenous pyelogram is not really useful. A conventional radiography is not really useful. And cystoscopy is not really useful unless it's a bladder cancer. In this case, it is not a bladder cancer because of the elevated serum calcium. So again, kidneys are associated with stones. Sorry, what am I saying? Like diagnosing stones and tumors in the kidney for CT, like we use CT scans. Your likely diagnosis is RCC with paraneoplastic syndrome. Now, just for the sake of completion, you may find a question that gives you other paraneoplastic symptoms. For example, they may have polycythemia, which indicates more like of an EPO release, like erythropoietin. You may have hypertension, which could be renin release, like a renin secreting paraneoplastic syndrome. You could have Cushing's, so like they'll secrete ACTH, so there'll be a fat, high levels of what do we call it? High levels of cortisol, high blood glucose levels, humps, etc. Or in this case, PTHRP, which was associated with hyperparathyroidism and hypercalcemia. All right. Next question. I think we're almost done. We just have a few more questions. So 32-year-old nulli gravida, meaning never pregnant before, woman, 34-year-old husband come to the infertility clinic because they've been trying to conceive for the past 12 months. During this period, they had unprotected sexual intercourse 4 times per week. Woman had four previous partners and her husband had one. Neither partner conceived before. The woman reports having regular menses, 30-day cycle. Her menstrual cycle her last one was 3 weeks ago. Um, the man had uncomplicated gonorrhea 10 years ago, but was treated promptly with ceftriaxone. They both take vitamins, no other medications on both. Their physicals are both fine. Urine pregnancy test is negative. What's your next best step here? All right, great. So it is a semen analysis. Again, the reason we do a semen analysis first in an infertility couple is because it's super cheap, super easy to get out of the way, and it can quickly diagnose any problems that a man has if they are the cause of the infertility within this couple. Tests that involve what do we call it, infertility in the case of women are much more expensive and invasive, and you don't want to really put a woman through that before like making sure that the man is fine because semen analysis is very cheap and easy to do. Serum testosterone and FSH levels comes next in the paradigm or the algorithm. Because you really need to find out first if the sperm are fine or not fine or low in number. Once you find that out and you find out that maybe they're not normal, then you could consider doing a serum testosterone and FSH level. The only time you would really reassure a patient and follow up in 6 months if they have been only conceiving for like say 6 months. If this question said they've been unable to conceive for 6 months, then your answer would be actually B in this case because infertility is defined as 12 months of being unable to conceive despite regular attempts. So if you see this number as 6, then you can follow up in 6 months. Other than that, your first line test is a semen analysis. So yeah, infertility is defined 1 year of failure to conceive. And then your first initial step is the semen analysis, as we discussed earlier. Let's move on to the next question. We have a 90-year-old man who presents to the clinic following for follow-up after colorectal surgery. He has a history of stage 4 colorectal cancer, and he has been in chemotherapy for 2 years. On digital rectal examination, his prostate feels very hard and nodular. Biopsy was obtained and staging was performed to reveal a stage 1 prostatic adenocarcinoma found incidentally. Which of the following is the best next step? All right, great guys. It is B. Again, prostatic cancer. He's 90 years old. He's very old. I don't think he'll be around for that long. And there's no reason to really put him through a surgery. And he has stage 1 prostatic cancer. He's already undergoing chemotherapy for another cancer. So really, you just leave this alone, just observe it, just follow up in a few months. If it progresses, if it say it becomes like stage 2 or something like that, then you can consider surgical options or hormonal therapy. Other than that, I would just leave it alone. There's no need to do anything in this case. The guy won't be around for that long anyways. So again, your answer is observation. Patient is really old, unable to undergo most procedures. Localized prostatic cancer can be indolent and should be followed through observation, since most men will die with prostatic cancer rather than with it. So here is the paradigm from the lecture. Um, for your local disease for prostatic cancer, your first option would be observation. Other than that, if you feel the need to remove the prostatic cancer, say it happens in a younger patient who's about like 20 years old, then I would consider doing options for like other options because it could be a familial variant which is very aggressive. So you could do a radical radiotherapy or radical prostatectomy. If it is an advanced disease, you can again do a radical radiotherapy or hormonal therapy. And if it is metastatic, surgery is not really useful. So you could go for hormonal therapy in that case. The same principle as any other cancer. If it has metastasized, then you would really consider just supportive therapy with hormonal therapy as well. All right. I think this might be our last. I don't know. Might be. I don't know. I don't remember. All right. So a 35-year-old woman comes to the emergency department because she has right flank pain that radiates to the groin. She has no history of other major medical illnesses. Her temperature is 36 degrees Celsius, which is for some reason very low. Pulse is 100. Her blood pressure is 110 over 60, and her urine dipstick is positive for blood. Further evaluation with laboratory findings will most likely reveal which of the following. Now, I want you to think here about the most common type of kidney stone, and then you can go for the answer here. So again, we're measuring serum calcium here, serum uric acid, urine calcium, and urine cysteine. Just think about the types of, what do we call it for the types of kidney stones you might run into. All right. So this is a little bit out of scope, just a tiny bit because I took this from Amboss. So it's a little it's a little out of scope here. But I think it is useful to know. Calcium oxalate stones are the most common types of stones in adults in general. So that would be the stone that we're orienting ourselves towards. Now, the reason calcium oxalate stones occur is because of deposition of calcium and oxalate in the kidney tubules. This happens in normal adults, which means that their serum calcium is expected to be normal in this case. That's the most likely finding that you'll find, unless they have a PTH problem. So that's why this might be high, which can predispose them to kidney stones as well. But that's not most people who get kidney stones don't have like hypercalcemia. So your other option would be a normal serum calcium with a high urine calcium. Now, the reason we have a high urine calcium, that is more likely to be common in people because people are more likely to have hypercalciuria as an asymptomatic finding. So if they have hypercalciuria as an asymptomatic finding, that predisposes them to the formation of kidney stones. And then if there is a factor that may push them towards formation of a calcium oxalate kidney stone, for example, they increase their intake of oxalate or they develop Crohn's disease, they can then develop kidney stones very easily because they already have high urine calcium. As far as uric acid is concerned, the only time I'd really think about uric acid is if she has symptoms of gout, which she doesn't. Gout is more like associated with arthritis, secondary to the consumption of red meat. So that's not really mentioned here in this question, so I don't really consider that. Um, if she has like PTH problems, if they really mention she has like constipation, she has what do we call it? Bone pain, she's been experiencing altered mental status, then I would consider more hypercalcemia, and then I could really pick D in this case. But since there's nothing really wrong with her except this kidney stone, then the most likely finding will be C, which is a high urine calcium. And which this finding is called a normal calcemic hypercalciuria, which predisposes to the formation of calcium stones. And the most likely calcium stones are calcium oxalate, not calcium pyrophosphate. So sorry, calcium phosphate, not pyrophosphate. Pyrophosphate is the thing that deposits in the joints. So calcium oxalate stones are the most common cause of nephrolithiasis in general, and they occur in people with idiopathic hypercalciuria. Oh, there's one more question actually. Okay. Actually, there might be a few. I don't remember. 63-year-old man comes to the physician because of a 3-month history of fatigue and constipation. He's having dull pain in the left portion of his mid back for the past 2 weeks, despite taking ibuprofen. His dad died because of prostatic cancer when he was 70. The patient has smoked 1 pack of cigarettes daily for 45 years. Vital signs within normal limits. Physical exam shows a left-sided varicocele, both in supine and standing position. He has varicoceles, keep that in mind. Rectal examination shows a symmetrical enlarged prostate with no masses. So it's symmetrical. Laboratory findings show a slightly low hemoglobin and normal creatinine, a high calcium, slightly high protein, and hematuria. Which of the following is the best appropriate step? All right, let's answer this question. This is again, we're looking at renal cell carcinoma in this case. You know why? Because the patient has a very high calcium serum calcium, and he has a left-sided varicocele. The reason there is a varicocele is because renal cell carcinoma can compress the renal vein, which the renal vein is a direct drainage, at least on the left side, for the what do we call it? The scrotal veins. And because this obstructs the outflow of blood from the veins, it can cause what do we call it? Dilation of the scrotal veins, which will cause a varicocele. That's why this patient has a varicocele in this. Uh, because this patient has a varicocele and because they have a high serum calcium, he most likely has a renal cell carcinoma. So in this case, your most useful modality would be an abdominal CT scan for the same reason we discussed earlier. Cystoscopy would not be really useful here because that is associated more with transitional cell carcinoma. KUB wouldn't really be useful in anything. I wouldn't really ever pick that option. And a scrotal ultrasound will not be useful even if he did have prostate cancer because it does not visualize the prostate. A scrotal ultrasound will be more useful if he has like a testicular problem. For prostate cancer, we really just go for like a physical exam, and then we can do a CT scan anyways for like osteoblastic lesions if it has metastasized into like the spine or anything like that. So just to confirm again, abdominal CT. Your what do we call it? I took this straight from Amboss over here. So for renal, this is specifically under the renal cell carcinoma article. Your modalities of choice are an abdominal CT, an MRI, or an ultrasound with contrast. Actually, they're all with contrast. So regardless of the modality here, you want to use the modality that will visualize the cancer best, depending on your patient. Now, obviously, if you have the option, you'd go for CT scan first. If there's a contraindication, then you would go with either MRI or ultrasound. That's when I would go with those. So, what do we call it? Other than that, it's very straightforward. I don't think they'll bring MRI or ultrasound. It's most likely going to be CT scan because that's what has been questioned in the past before, and that's what most questions will examine you for. So again, so what I want you to remember about renal cell carcinoma is that it can cause paraneoplastic syndromes. So it can appear as an elevated calcium or an elevated hemoglobin. If you see an elevated hemoglobin, say about 20, which is also high, it could be a paraneoplastic syndrome associated with renal cell carcinoma. The same thing goes for like what do we call it? Like calcium, renin. If the patient has very high blood pressure, if you see like a blood pressure of 180 with high renin, it could also indicate a renal cell carcinoma. So other than that, it should be pretty straightforward. So the way you diagnose renal cell carcinoma is an abdominal CT, as we discussed earlier. And that's all. That's generally all I found because the lectures are super simple, super easy. There are only 4 lectures from urology. So the questions are pretty straightforward, very easy. Um, Most of these questions were actually collected from outside, based on like AMBOSS, based on URL, mostly related to like your exam questions. That's why they were a little confusing, maybe a little difficult. Other than that, that should be it. If you have any questions, you can ask me on the chat directly. If you don't, you can always just contact me here in the beginning. I left my email. If you have my phone number, you can also contact me on there, whatever you really prefer. So that's it, honestly. No worries, guys. Good luck on your exam. Your exam's on what do we call it? Your exam's on Sunday? All right. That's good. Are you guys prepared?